Hey, good afternoon. I'm Katrina Hoff. I'm the director of the Southwest Idaho Area Health Education Center. And this presentation is part of our continuing education series that we do annually in partnership with Full Circle Health. I would like to let you know that no one involved in planning or presenting this activity has any relevant financial relationships to disclose. We are happy to have Dr. Sasha Pashchenko with us today talking about testosterone as an intervention in postmenopausal HRT, current evidence and guidelines. And we would really appreciate it if at the end you would complete the post-session evaluation. With that, I will hand it over to Dr. Pashchenko so she can get started. Oh, I also want to let you know, please feel free to post questions in the chat, and there will be some time at the end of her presentation for you to pose those questions. At that time, you'll be able to, I can read your questions. You will also be able to unmute yourself and just ask the question verbally if you prefer. So thank you, and I will hand it over to you, Dr. Pashchenko.
Perfect. Thank you so much. And thank you everyone for coming to see this talk. I just want to start out by saying that I initially became interested in this topic because I have had some patients who are getting kind of HRT with estrogen therapy and menopause. And more of them were kind of asking about testosterone. And I was working with Hannah Underdahl as well. And it seems like more and more patients are interested in kind of knowing about all the hormone therapies that are available in menopause. So I kind of chose to talk about testosterone specifically today because that's kind of a more niche topic. So that'll be the focus of my presentation, and we'll kind of get started. So this is kind of the mandatory disclosures slide. I don't have anything to disclose. And then just a disclaimer for this presentation. I do use the words female and woman to describe people born with female reproductive organs, but I do want to acknowledge that these words don't describe all people who undergo menopause symptoms. So I'm using these words female and woman to stay kind of consistent with research documentation and to represent the biological sex at birth and not gender. So just wanted to kind of point that out and make sure we're kind of aware of the lingo that I'm using in this presentation. So just overall for this presentation, I just briefly want to go over the objectives. The main kind of topic for this presentation will be about testosterone, but I will spend a few slides kind of reviewing what menopause is, menopause symptoms, and kind of current treatments that are more common with like estrogen therapy. And then after that, I'll dive into a little bit more about testosterone physiology in females and kind of indications to prescribe testosterone, potential benefits, kind of side effects, contraindications, how to monitor the patient's like symptom side effects when you do prescribe it. I do also want to kind of go into detail and outline how to prescribe it and kind of some challenges that come with this. So you'll be kind of set up to potentially be able to do this yourself in clinic if you're interested. So that'll be the overall general topic. And then at the end, I kind of review some limitations with some research that's been out there as well. Okay, so just a brief overview of menopause. So the average age of women that undergo menopause is around 51, and around 95% of women will become menopausal between ages 45 and 55. So that's the typical age range you should be asking women about this, asking about symptoms, kind of broaching that topic. It should be part of kind of your general wellness exams and making sure that you kind of stay on top of awareness for this. So there's a lot of symptoms that women can have with menopause. So insomnia, mood changes and irritability, hot flashes, brain fog. You can get heart palpitations, genitourinary symptoms, vaginal atrophy, joint aches and pains, and many others. And I've actually seen a couple of patients in my own clinic that have kind of presented with chronic problems for insomnia and joint aches and pains. And those are obviously problems that kind of can get lumped in their own kind of bucket and get worked up kind of isolated from menopause. And sometimes it just takes kind of a new set of eyes to kind of step back and see that constellation of symptoms and that it might be related to menopause and maybe they would benefit from treatment for that specifically. Okay, so I'll just review kind of typical therapy for menopause. And it's typically, so estrogen is typically prescribed to control kind of peri and postmenopausal symptoms. And I won't go into detail on how to prescribe estrogen and progesterone. That's kind of a really in-depth topic that kind of needs its own presentation, but Up to Date has a lot of really great information on how to do this and how to monitor therapy. But I just want to kind of give a brief overview of kind of what therapy is and the importance of it before diving into talking about testosterone. But in general, estrogen is prescribed and it can come in many different forms. So isomolecular estrogen, usually prescribed as estradiol. There's also synthetic forms. There can be the vaginal estrogen, transdermal, the pill, and then progesterone typically is prescribed to protect the uterine endometrium from kind of risk of endometrial cancer. So in somebody that also has a uterus, you would also want to prescribe progesterone. And again, it can come in isomolecular and synthetic forms. There's a pill, or you can even do like a progesterone IUD. And then testosterone is kind of this third hormone that's, I think, picking up kind of in popularity to kind of think about and talk about in conjunction with estrogen and progesterone, and kind of how does this fit into menopause. Can be prescribed kind of transdermal. There's also injectable forms, and kind of the newer kind of way to describe therapy with both estrogen, progesterone, and testosterone is this new term called PET or PET therapy, where you kind of do all three. So that just a little bit of info on lingo there. So I do want to kind of talk about the importance and the benefits of prescribing hormones in menopausal women. So the main benefit that you get is you treat their symptoms. Their symptoms of menopause can be really bothersome to a lot of women. So that's the main goal with treating them with estrogen and progesterone. But it's also shown clear benefits, especially if you start them pretty close to undergoing menopause, so ages 50 to 59. A lot of research has shown decrease in all-cause mortality, decreased fracture risk, decreased risk of developing type 2 diabetes, and maybe even some reduced cardiovascular risk, though there's some kind of mixed evidence there, and I think more studies need to be done. But overall, you get a lot of these really great benefits. So I think it's really important to kind of offer and talk about this with your patients. And I just want to point out that there's a lot of fear, I think, around prescribing HRT in menopause, and maybe even just not knowing how to do it. And I'll kind of talk about why that is, and why kind of a lot of doctors aren't familiar with this, and why it's not being kind of taught as much as maybe it should be. But there was one study that showed that in 2020, only about 4.7% of postmenopausal women were on any kind of hormone therapy. So very low kind of treatment numbers. And I think that's both potentially fear from the doctor side, but also maybe fear from the patient side. I'm sure they've heard a lot of risks with getting hormones. So there needs to be kind of a lot of education to be done around this topic. But a lot of this kind of fear and lack of education around this topic, I think, stems from this one large kind of early study that was done that kind of concluded that there was increased risk of breast cancer, cardiovascular risk, and increased mortality. But since then, there have been kind of additional evaluations done of that same data that actually found that they kind of misrepresented and misinterpreted their own data. And the study was also done on a population that was more than a decade out of women were more than a decade out from menopause. So that kind of skewed the results for a specific population. And we now know that it's a little bit more safe to prescribe it kind of as soon as they kind of undergo menopause to have the most benefits and the least amount of risk. So because of this huge study and a lot of kind of news and publicity on this, I think caused this topic to really not take off and not be taught about as much. So I think there's been kind of slow and more research that's being done that's kind of helping us get back into being more comfortable prescribing hormones in menopause. And really the main contraindications that you should be looking for before like that would maybe make you hesitate to prescribe hormones in menopausal women would be some ones listed here. So like a personal history of breast cancer, coronary heart disease, previous VTE event, stroke or TIA, active liver disease, and unexplained abnormal vaginal bleeding, which you would want to work up. And then any high risk for endometrial cancer. And as you notice, some of the contraindications that aren't on here is smoking, obesity, and a family history of breast cancer. So if a patient has some of those, it might require you to kind of think about those things, but it's not necessarily a contraindication if they're smoking, obese, or have a family history of breast cancer. So just something to think about and making sure you're not denying somebody hormone replacement therapy from some of those other things. Okay. So now that we kind of have a general kind of overview of what menopause is and the importance of treating them with estrogen therapy, how does testosterone fit into the picture? So testosterone physiology in females, the testosterone is made both by the ovaries and by the adrenal glands in females. And testosterone levels over time, they peak around the third and fourth decade of life and then kind of slowly, gradually decline after that. So unlike estrogen and progesterone, which kind of rapidly drop off around menopause and then stay low, testosterone acts a little bit differently, and it's this just really gradual, slow decline. So it's not necessarily something that kind of you'll automatically need testosterone replacement around the time of menopause because it does act in the body slightly different. So the main indication, so kind of based on research and current guidelines, the main reason that you'd want to prescribe testosterone in peri or postmenopausal women is for hypoactive sexual desire disorder. So if they're having problems with sexual desire specifically, that would be an indication to start testosterone. Currently, there's no other specific like guidelines that would indicate that you start it for any other symptoms. So that's kind of based on current research. That's the main reason you'd want to prescribe it and offer it to a patient. And there are some other potential benefits, but before we start prescribing it just for these other benefits, I think more research needs to be done and guidelines need to be kind of developed. So we don't necessarily start it for these other benefits, but there are some studies that have shown it can also help with vaginal tissue health, potentially cardiovascular health, can help with cognitive function. There's no clear benefits yet to kind of bone health or muscle strength. But again, this is pretty new topic and most studies are on the smaller side and haven't quite dived into the clear benefits yet. So I don't think we can fully kind of rule out some of these other benefits from testosterone use. So if you have a patient and they are, let's say they're already on estrogen and progesterone for menopausal symptoms. They're feeling a lot better, but they're still having kind of low sexual desire. And so you decide to start them on testosterone to see if it will help with that for them. So the main things that you want to counsel them on for side effects would be there's some reversible side effects. So they might start to get some acne, they might get some mild androgenic hair growth, some weight gain, some mood changes. And the goal is to have their testosterone level be closer to what the physiological ranges were prior to them having kind of undergone menopause, so kind of back in their 30s and 40s. So theoretically, these side effects that they have shouldn't be significantly worse than what they might have experienced back then. And then testosterone can also be metabolized to estrogen. So they might also have some estrogen-like side effects like breast tenderness, irregular bleeding. So important to kind of counsel them through these things as long as they're getting kind of appropriately monitored. These are some of the mild side effects they might have. And then there is a risk of kind of irreversible side effects, and these only kind of come up if you're getting to the supraphysiologic dosing ranges. So still important to counsel them on these because if they are kind of lost to follow-up or if they're taking the testosterone not as prescribed, they are at risk of having these. So irreversible side effects might be like deepening voice, clitoromegaly, androgenic alopecia, and hirsutism. So still really important to talk about these and kind of talk to them about the importance of appropriate follow-up, appropriate dosing to kind of avoid these other irreversible side effects. And then it's also really important to counsel them on risks. So a lot of women that might be interested in testosterone or aren't sure about it, they might have some fear around it or might think that there's a lot of risks associated with it. But overall, you can tell them that it's very safe. There's a lot of studies that have been done over many decades that have shown that testosterone therapy, when appropriately dosed and monitored, is very safe for use. And there was even a large kind of meta-analysis done of 36 randomized control trials that had 8,400 participants that showed that using transdermal testosterone showed no significant adverse events, and it showed significant improvement in sexual desire, arousal, and overall reduced sexual concerns. So overall, based on a lot of these different studies, it's very safe. A lot of studies also show no increased risk for breast cancer, no effect on blood pressure, lipids, or A1C, or even breast density on mammograms. And hard to know how kind of exactly how this correlates to some other longer term outcomes, but it's great to see that it kind of overall has a nice like safety profile. And sometimes we'll get some of these things like labs to monitor like lipids and things like that, but it doesn't necessarily, the research hasn't shown that it actually affects it all that much, especially the transdermal testosterone. And then just some limitations to think about for some of these studies. A lot of them did exclude women kind of at high cardiovascular risk. So just something to kind of keep in mind and think about. But again, if we're kind of prescribing it earlier on in younger women, theoretically, it should be a little bit safer to prescribe. And then some limited studies did show some potential for increased risk of DVT, but again, most of these studies were done on women also taking estrogen, and they were kind of smaller and like retrospective, so hard to know exactly like causation correlation there. But I think the big moral of the story is that there does need to be more studies done for this. But it is safe to say that overall it seems pretty safe with no significant big adverse events reported, at least. And then I do want to go into detail on how to prescribe testosterone. It can be very daunting and very hard to kind of listen to a presentation and then get all excited about being able to do something or prescribe something, and then you kind of get stuck at exactly what do you order, exactly how do you write the prescription. It can be pretty daunting and hard to do, especially when there's not always great kind of guidelines or options available on like up to date that you can easily reference. So what I would recommend is if you can find somebody who's prescribed it before, that way you can kind of phone a friend if you run into any problems. That's always the best way to kind of get started with something that you've never done before or prescribed before. But hopefully this will at least get you more comfortable and start to think about this and hopefully think about prescribing this in your clinic. But a lot of times testosterone will be prescribed last, kind of after you've already started estrogen and progesterone. And you'll kind of see what remaining symptoms do they have. Because sometimes maybe their sexual desire concerns might be related to effects of lack of estrogen, like vaginal atrophy, vaginal dryness, that type of thing. So sometimes you kind of can suss that out. So unless their only symptom that they're presenting with is sexual desire concerns, most of the time you'll probably end up prescribing kind of estrogen and progesterone first and kind of see how they do with that first. And then the hard part is that there's no formulations for kind of physiologic levels of testosterone for females in the US. So most of the products that are created are for men to kind of have men physiologic levels of testosterone. So the levels that females need are much lower, and they don't really make many products here for that. Sometimes compounding pharmacies will. Other countries actually are a little bit ahead of us on this. And so there's other countries that do have like female testosterone patches that release kind of the exact amount of testosterone that a female kind of levels of a female that they would need. But unfortunately, we're not there yet. So we have to kind of jerry rig the testosterone that is available to us here. So usually what gets prescribed here is topical testosterone gel. And usually it's the formulation that men use. So men would use kind of 5 grams per day. Women, it's dosed at 1/10 of the male dose. So you can get this 1% in cream, ointment, or gel. And there's kind of several different kinds of like packaging for it. So they can come in tubes or pumps. So there is a little bit of kind of work to get familiar with what's available at different pharmacies, but that's kind of the main thing. And so for women, you would use 1/10 of the 5 grams, so 0.5 grams per day. So if you're doing kind of a daily tube that men would use, you would do a 1/10 of that, and it should last them about 10 days. And when talking to somebody and before prescribing this, it can be expensive. So it is kind of important to talk to them and warn them about the cost. There are some coupons available with like GoodRx. You can kind of familiarize yourself with which pharmacies might have kind of cheaper versions. And then there are also like some compounding pharmacies that might have testosterone products available as well, but they do tend to be kind of more expensive. So it can take a little bit of work to kind of familiarize yourself with kind of what pharmacies are in the area, what they provide, and how much would it cost for your patients, because usually insurance wouldn't cover this. So it is kind of an out-of-pocket cost. So when you are prescribing testosterone, the prescription script that you want to use is, so you'll be prescribing testosterone, usually a 1% gel. And the instructions that you want to kind of write out for the patient is that to apply 0.5 mLs or 0.5 grams, which is about 2 kind of small peas sized like dollops. And you want to apply those to kind of the back of the calf or outer thigh. And you do kind of want to talk to them about how this can get absorbed through the skin. So if they're around kids or anybody else who might be touching kind of those areas that they're applying it to, they just want to be careful kind of exactly who's touching those areas, and then just making sure that they're washing their hands after applying it. Because if you do have residual kind of gel on your hands and then you go touch another person or children, it can get absorbed through their skin as well. So just counseling them around that. And then just letting them know that if they're doing kind of the daily 5 gram tubes, that each tube should last about 10 days for them. Okay, and then you can dispense around 45 grams. You can do kind of how many ever refills you'd like, depending on how chronically they've been on it or if it's something new for them. The main transdermal formulations are, if you're using kind of the male physiologic dosing formulations, it's usually these 5-gram tubes, which are much more affordable, but you need to be very careful about how to educate them on dosing so they don't get too much or too little. And it can end up being a little bit variable in terms of how much they're getting day to day, because they're not kind of these discrete volumes. There are also some compounded formulations that are available that are easier to dose. So like Versa-based cream is one available option that is a little bit easier to dose. I think it comes in like a specific, like each click or pump provides the exact amount you need each time. But again, it ends up being a little bit a decent amount more expensive. So kind of depends on the patient population and the person you're prescribing it to. So kind of weighing those pros and cons of, is it easier to dose? Like, will the patient be able to kind of understand the instructions I'm giving them? Cost versus kind of benefit to that. Okay. And then shout out to Hannah Underdahl, who took these wonderful pictures to kind of educate and show people exactly how much testosterone gel to kind of tell patients to take. So this is kind of a little 5-gram tube, and you want to measure out 0.5 mLs or 0.5 grams. And there's kind of a 1/8 of a teaspoon for reference. And then she put 2 little frozen peas for reference for size of exactly how big that dollop is. And then if you want to be really kind of cognizant and know exactly how much you're giving each time, you can also send in a prescription for these syringes that the patient can pick up. And they can kind of draw up all of the gel from that tube, and then they can slowly dispense a 1/2 of an ml each time. And that can just be a little bit more precise in terms of how much they're getting each day. So a lot of patients, if they're comfortable with using kind of a syringe to do that, it can be a very helpful tool in their pocket, because kind of having a day-to-day fluctuation in the amount of testosterone you're getting can change kind of how people feel. So it is important to have some stability in the amount that they're getting. So I think these pictures are really great to kind of outline. And I think being able to show patients kind of exact pictures or instructions can be really helpful to making sure that they kind of understand exactly how to dose it, and it prevents any of those kind of scary, irreversible side effects of them accidentally getting too much. Okay. And then you've prescribed this, but you do want to think about kind of what the monitoring will look like. How often do you want to see them back? Do you need to get any labs for them? So when you're first seeing them, I think important to kind of consider getting lipids, liver function, a CBC. And part of this is to kind of assess for any underlying diagnoses that you might not know about. So underlying like liver dysfunction would be really important to know about. Like CBC, usually we worry about the CBC more at like male physiologic ranges of testosterone that can cause like high hemoglobin counts. In this case, it's much less important because we're not getting anywhere near those testosterone ranges. And then lipids. I think some studies have shown that like the injection testosterone could affect lipids a little bit, but transdermal hasn't really been associated with it. But worth kind of getting those, kind of helps you assess their cardiac risk in general as well. So those are important to kind of think about kind of at baseline, and then you could consider getting them kind of annually or as needed after that, depending on kind of their underlying health risks and in general, just kind of doing it more of a case-by-case basis. There's not really any clear guidelines for this. And then what there is kind of more guidelines about is you do want to check a total testosterone when you're starting somebody on testosterone, and then you want to monitor it pretty regularly until they're stable on a good dose. So the goal is to get them to premenopausal levels of testosterone. That general range is usually 50 to 70, but you kind of just want to use your reference lab normal ranges because they do vary a tiny bit. And even up to date, I think vary slightly from this number. So you kind of, there's not like a exact clear perfect range. I think they all vary kind of by 5 or so in either direction. And then some women might have symptom improvement at lower ranges, so you might not even need to quite get to those levels, but that's kind of the safe range that you can stay at. And then timeline is for lab work and kind of follow up is you want to get baseline labs when you're first starting it. And then you want to see them back in about 3 to 6 weeks, get repeat labs, make sure that they're not getting too much testosterone. If their testosterone is elevated at that kind of 3 to 6 week appointment, it's higher than that range that you want, then you will want to decrease the amount they're getting. So if they're getting kind of 2 pea-sized amounts, they can try to do like 1.5. And then you want to recheck kind of every 2 to 3 weeks until they're in that desired range. If at that point they're in the desired range by that 3 to 6 week appointment, then you can schedule their next appointment kind of 3 to 6 months out. Check again at that point. And then if they're stable, you can kind of do another maybe 6-month appointment. If they're still stable, they're doing really good on their regimen, you could potentially go out to annual appointments at that point. And then you also want to assess for benefit from this. So usually by 3 months, they should notice quite a bit of improvement in sexual desire symptoms. So if by say 3 to 6 months, they notice no benefit at all, then it's definitely warranted to stop treatment. Because by that point, if they've been in kind of the therapeutic range for those 3 months, then they probably won't notice benefit kind of if you prolong the treatment. And then you do want to be a little bit considerate of if you're treating somebody in the perimenopausal period, that they still might be having periods. They still potentially could be of reproductive age. So you just want to be really careful in those age groups that they are on some kind of birth control, or you might want to do more frequent monitoring or making sure that they're not at risk of getting pregnant, because it'd be very bad to kind of prescribe testosterone in somebody who's pregnant. So just kind of something to think about. And if it's somebody that you don't think that you think might be at risk of getting pregnant, kind of waiting maybe until they're menopausal and haven't had periods, and kind of that they aren't at risk of getting pregnant before prescribing this. Okay. So just kind of thinking about this whole topic as a whole, again, there's, I think, still, despite kind of these additional studies that have been done, and there's still ongoing studies being done, I still think that there's going to be and going to continue to be a lot of kind of hesitancy and fear around prescribing this by a lot of providers, and a lot of patients are going to come in with a lot of questions of how safe is this? What's the risk profile? Is it worth to try it? So it's really important for us to be able to kind of talk to them about those risks. And sometimes it's hard because research can be kind of very nebulous and hard to talk about in concrete terms, especially to patients. But I think overall, you can tell patients that as long as they're kind of coming in for monitoring, they're getting evaluated for any kind of high risk disorders prior to starting this, that it can be very safe and effective. And so as long as they're coming in regularly, I think you can reassure them that it's a safe therapy to kind of pursue, but you do want to kind of talk to them about that the main indication for it is kind of hypoactive sexual desire disorder, so that it will help them with their sexual symptoms, but it might not necessarily help with kind of any other symptoms that they might be having. So just something to think about. And then if you're still nervous about kind of prescribing this or prescribing it to patients, then just familiarizing yourself with kind of other providers or resources in the area for somebody who might be willing to prescribe this. I think there are some kind of clinics in the area. I've noticed this more with some of our male patients who are getting treated for low testosterone. They'll go to some clinics in the area that are kind of more functional medicine type clinics that will get started on testosterone without the appropriate workup. So kind of thinking through, if you don't prescribe it safely, maybe they'll go somewhere else that will prescribe it unsafely. So just thinking through that. And I think it is important to kind of learn how to do some of these things and at least educate patients on the importance of like appropriate monitoring. And then just to think through some of the specific limitations for the studies that I was reading through. There do need to be kind of more specific studies done on long-term outcomes. So there's some kind of peppering of information on that testosterone might help with cognitive function, maybe bone density, maybe with cardiovascular outcomes, but haven't really been a lot of really good concrete studies like randomized control trials or anything like that that have looked at these things specifically. So I think it's going to take lots more years to kind of get some more concrete information on this. But I'm kind of looking forward to the studies that do come out on this. And I think there are studies that are coming out kind of year by year, and I'll be excited to kind of see what those show. And then trying to think through like some of the studies I looked at, some of them are confounded by estrogen use, and majority of the time you'll be prescribing testosterone in somebody who's already getting estrogen. So I think overall it is something that does kind of typically represent the patient population we see, but just kind of sussing out risk that's directly associated with estrogen versus testosterone might be a little bit more difficult. So I think specific studies need to be done and kind of comparing those two groups. And then thinking through that a lot of these studies are usually done on kind of healthier people, lower cardiovascular risk. So thinking through if you do have a kind of a sicker patient, higher cardiovascular risk, history of kind of active MIs or multiple stents or anything like that, just kind of thinking a little bit more critically about that. And maybe just doesn't mean that you can't prescribe it. I think just making sure that your patient is aware of that there's not really enough studies done around this population. Because some might find that the benefits of getting treated with testosterone outweigh the risks, these potential risks. So I think just really important to counsel them and kind of let them make an informed decision as opposed to saying, no, they can't be on hormone replacement or testosterone. And then some other challenges that come, just to review, that there's no like female formulations for prescriptions for these testosterone like products, which can be really hard for providers to kind of dip their toes into being able to prescribe it if they put a prescription in and then the pharmacy kind of calls them back and says, I'm not familiar with this. This is a weird prescription, because they're used to kind of these male formulations being prescribed to men at certain doses. So you might get pushback from pharmacists. You might have a hard time kind of educating patients on how to administer it in safe doses. Or you might run into the problem of it being kind of a lot more expensive, especially through like compounding pharmacies. And then just in general, it being expensive for patients because insurance doesn't cover it. They have to pay out of pocket. So kind of finding ways that you could potentially try to make it a little bit more affordable for patients. So kind of using those 5-gram tubes, at least from what I've heard from Hannah Underdahl, those, at least in this area, she found to be a little bit cheaper. and the kind of compounding pharmacy formulations end up being quite a bit more expensive. So just counseling your patients on all of those things. I think this is just a topic that is really important to make sure we talk to our patients about in detail. And if you're not able to or don't want to kind of get into prescribing this, just kind of knowing who in your area can do this, so then you can appropriately kind of refer them and make sure that they get treatment for this specifically. Okay, and then these are just some of my references. A lot of these articles are really good to actually dive into and read. So there's like the global consensus position statement on use of testosterone therapy is that first one on here. And that's kind of the most comprehensive kind of article that I found, that they kind of analyzed all of the research that's been done so far and kind of got a panel of experts together and said, okay, here are the guidelines we can kind of tell physicians to follow based on what we know so far. So that was really helpful to see. And then there's quite a few different articles on UpToDate there at the bottom that I found really helpful, especially for like estrogen and progesterone therapy. And there's, especially for estrogen therapy, UpToDate has this really nice table of all the estrogen products and what formulations they come in and what doses and what brands. So I found that really helpful. Unfortunately, there's not one like that for testosterone, and the number of products are a little bit more limited, but definitely check out some of these resources when you're kind of diving a little bit more into this topic. Okay, any questions from anybody?
I just had a quick question regarding all of this kind of was in the context of menopause, but curious if you ran across anything for patients that have had a hysterectomy and like if you can use that or whether things changes or if there's any resource you would recommend I look into.
I didn't specifically dive into that, but a lot of times, at least for like estrogen progesterone therapy, I guess for somebody who's had like their ovaries removed, that like date or time for when they have undergone menopause kind of moves up to when their ovaries were removed. But kind of just for a hysterectomy specifically, I don't know that there's much like difference.
Sorry, I should have clarified
Yeah.
ovarectomy, but
yeah. Okay, perfect. Yeah, that's kind of what I assumed you meant. But yeah, I assume it kind of just moves up that timeline to like when they're hormonally deficient, as soon as their kind of ovaries are out, and kind of just thinking back to like the physiology of testosterone in women, like it is produced in the ovaries to some extent, but then they don't quite have that same drop off at menopause. But maybe that drop off might be more rapid if they're being surgically removed. So definitely a consideration. And I think, again, just thinking through like as long as you're kind of being safe with the monitoring and application of the testosterone, I anticipate it'd be definitely something you could try, especially for kind of sexual desire dysfunction in that population. Okay. Any other questions?
There is one in the chat, and if I'm not mistaken, I believe this is related to the testosterone prescribing. The question is, can you prescribe 30 tubes or one box? I know that's a long supply for a controlled prescription. I have some pharmacists who will and some who won't.
Yeah, and I have actually like limited experience with this myself. I know Hannah Underdahl has prescribed it quite a bit, so she might be a good resource to reach out to if you're familiar with her. But I think to some extent, I know Hannah specifically has developed kind of a good relationship with a specific pharmacist, and she directs a lot of her patients there because the pharmacist knows her. They're familiar with exactly how much like testosterone that she prescribes at a time. And so I think just maybe developing a better relationship with specific pharmacies and kind of directing your patients there, as opposed to kind of sending the testosterone to whatever pharmacy the patient wants and then running into problems of the pharmacist being unfamiliar with it, or kind of just being a little bit proactive and either writing in the notes comments that this is exactly what you want and you're aware of what you're prescribing, or calling ahead. So I think that a lot of people have run into problems with just pharmacists like pushing back, with like the amount or with, kind of how the prescription is written. So it is something that you kind of have to overcome as some obstacles, unfortunately, for this.
Yeah, that was me who posted that comment, and I have talked to Hannah, and I've tried several different ways, and I still get pushback. So, like, none of the Walmarts will do it. I find Save-Ons are a little more liberal, but then I have some that will say no. So yeah, I haven't ever found a specific place I can always go to. And then, the patient has their preferred pharmacy that their insurance is at and everything. And then I send the GoodRx coupon. This has been great today, and I've learned more, but I had previously learned from Hannah about some of this, but there's still quite a few barriers to get this for women.
Yeah, and it's really unfortunate. And hopefully, as more research kind of comes out, that maybe there will be kind of more FDA approved products that come out. And I'm surprised more people aren't like, somebody isn't capitalizing on this and creating like a product that women can use. They would make a lot of money even if they made it pretty affordable.
Yeah, I think if more providers started writing it, they would get more comfortable doing it too. So hopefully this helps. Yeah.
Yeah.
Hey, Sasha, I have one question for you. First of all, really good talk. Thank you. You talk about the testosterone only formulation. I have women who come in asking for the combined one that's just localized, like just clitoral testosterone. So, I mean, what did you read about that in comparison to treatment for even for this, or is that for a hypoactive sexual disorder versus just more for pleasurable intercourse?
Yeah, I didn't specifically run into that kind of based on the research that I was looking at. And I'm kind of less familiar with that in general, so I don't want to say anything that's kind of wrong or misguided. So I'm just going to say that I don't know much about the topic, but I assume that it's probably much lower doses and not systemically absorbed. So probably an option. I think some of those products are available like over the counter. So probably safe to try if like a patient isn't willing to kind of come in for these recurrent visits to get like their testosterone monitored, is probably kind of what I can say from my limited knowledge.
Yeah, I mean, I just have patients who come in and like, I want Scream Cream. And I was like, what do you want?
Yeah.
So I was like, that's great. I'm all about that for you. But
Yeah.
okay. I didn't know if it came up. Thank you.
Yeah. And then I think Winslow commented a question here. Are there any mood side effects, desired or undesired? So there are some studies done on like cognitive function. I think a lot of it is around kind of having a better mood. Again, they're not super conclusive. I think I have seen Hannah kind of talk about this to patients that it might help their mood, and kind of talking about it as a theoretical, like it won't definitely help your mood. But it's definitely something that you can consider in someone who's kind of started estrogen. They are starting to feel better. Their mood is better. They have less brain fog, but it's still kind of there even at like an optimal dose of estrogen. And so you could consider talking to them about that, kind of as an off-label indication, but no clear guidelines on this being a benefit quite yet. Okay, any other final questions?
If there aren't any other questions, I just want to thank you, Dr. Pashchenko, for an excellent talk, and encourage everyone to join us next month on November 12th for family planning for PCP with Dr. Buning. Am I saying that right, Winslow?
Buning.
Buning? Okay, thank you. And we'll hopefully see you then.
Awesome. Thank you,
Thank you.
everyone.
Bye.
Bye.
Thanks so much.